G'day, it's Dr. Kieran Richardson, specialist physiotherapist and the director of Global Specialist Physiotherapy. I'm very excited to be speaking to Brad Beer from Pogo Physiotherapy on the Physical Performance Podcast.
Dr. Kieran Richardson, welcome to the Physical Performance Show.
Brad Beer, it feels great to be on here.
We've had a few goes at connecting over the years, and Kieran, the topic of conversation today is certainly one that's very well within your wheelhouse. I think in our industry, if you think Kieran Richardson, ACL management is definitely something you associate with you. And over the years on the Physical Performance Show, Kieran, we've explored the rehabilitation of surgical ACL patients with Mick Hughes. We've also looked at the POP book that was outputted by Jess Cunningham. But for a variety of reasons, we are yet to tackle the conservative management of ACL injuries. And as I reflected on the reasons for that, I think part of it was my own professional bias. Up until recently, studying a specialisation process here in Australia through the Australian College of Physiotherapists in the sports and exercise stream, which you encouraged me to do, I really hadn't my head down the rabbit hole too far to really look at this. But now that I have, I feel it's time that we bring this to the listenership of the Physical Performance Show. So it's a big topic, Kieran. But should we just start with some of the real practical basic things, almost like a walkthrough for an ACL injury? Firstly, what is the ACL, Kieran?
The ACL is the anterior cruciate ligament, and it's one of the ligaments within the knee joint that connects the knee top to bottom, back to front, and it has a role in stabilizing the knee, particularly stopping the shin coming forward on the knee, but also in rotation when the knee's fixed on when the foot's fixed on the ground, sorry. And yeah, it's kind of synonymous with sporting injuries, and anyone who's got an interest in sports would have heard the term and the acronym ACL. It's just so common. Most people in the general population have an idea of that it's a part of the human body and it's associated with common sporting injuries. Yeah.
And what are the mechanisms that can disrupt the ACL ligament or rupture the ACL ligament or sprain or the ACL ligament, Kieran?
Yeah, there's a few. I guess the most common ones you'll tend to see will be athletes who are running in a direction. They'll then decide to change direction with their foot planted on the ground, and their knee will turn in, and it's almost their body will keep going and then one way, and the knee twists in another way, and they'll hear and feel a pop oftentimes, and then they'll collapse to the ground with pain and swelling thereafter. That's probably your most common without contact. So they're just running and then they'll change direction and feel it, or generally it's at a faster pace. Some patients will be contacted, so they'll be hit by another player, or I've actually had a patient hit by a cow before, would you believe, when he was giving birth to it, which is a whole nother story. So it can be contacted. It can also be in hyperextension. So some patients will rupture their ACL when their knee's extended beyond its natural confines. And then you can have workplace accidents and things like that as well, which I do see in my career. Yeah.
And how common are ACL injuries, Kieran? Obviously, it's more associated with certain sports, and in Australia we have the AFL, and it's a very well publicised game. So the public tends to hear about players rupturing their ACLs, but how common are these injuries?
Extremely common. It's extremely common. So in Australia, it's a very, very common knee injury every single day. Patients around Australia, let alone the world, are having these injuries. And yeah, I guess what fascinates me and what I try to get my head around is, once the injury's happened, what are we deciding to do with this patient? And what are the reasons for that? And specifically, what evidence are we using to inform that decision? And that's where, I guess you mentioned the rabbit trail. That's where it gets a bit more interesting. And I think it's a very, very hot topic currently. I thought it was a hot topic when I started looking into it around 10 years ago, but it's even more so now. It's taking off, and it's exciting to be a part of it.
And you're very much at the fore of the conversation domestically here in Australia, but also internationally. You know, you're sought after for your opinion, particularly on the conservative management side. It certainly doesn't mean that surgical options aren't there for patients, and you're very balanced in your approach. Just before we jump into the management of these injuries, Kieran, why does the ACL matter so much in terms of it as an injury?
Well, I guess it matters because anyone should ideally have not had the injury in the first place. So it's important that if you can avoid having an ACL injury, you want to do that. And that's a whole nother topic. And there's experts in the field who could produce data more readily than I can. But it's very well known now that you can prevent the risk of having an ACL ever by doing a prevention program. And that should be happening at a grassroots level. It almost always happens at the elite level, and semi-professional level. Sometimes it doesn't. But there's high quality research that doesn't actually need to be investigated anymore. We know these programs work, but it doesn't happen. So it's important because it helps you have a more normal body. If you haven't injured it, it's always best. But if you have it injured and then it's not correctly stabilized, however that may be, assuming it doesn't heal, your muscles in your leg are strong enough to cope or take over the effect of the ACL, or it does heal, it needs to heal satisfactorily so that you can return to the sport that you were doing before with mitigating risk, or whether surgery is necessary. And so it's super important that once you injure it, that you have some kind of stabilization protocol that's employed. And so that's where we can kind of tease that out, the specifics of it. And it depends, because there's a large group of patients that once they have the injury will opt against going back to their previous sport. And there's a lot of wisdom in that. And so that's another whole part of the conversation, which we probably should touch on, because, we don't necessarily want to be giving patients this assumed golden ticket back to their pre-existing function, because a lot of the time that doesn't happen, including at the elite level.
And we're going to explore that with the different options people have to rehabilitate their ACL injury. Kieran, I think if you polled people on the street about an ACL injury, one of the associated comorbidities that they would be concerned about is the rate of knee osteoarthritis. Look at this specifically with the options that people have in managing their knee, but anything you just at the top of this conversation share around that, about when people disrupt their ACL, have an ACL rupture, their prognostics around knee osteoarthritis as their life goes on.
Yeah, look, I was at a National ACL Symposium in 2017, and the famous quote by Karim Khan, who's a professor of sports medicine, sports doctor, he said that basically once you get an ACL injury, it's a diagnosis of osteoarthritis. Now, I feel like that's probably a little bit of a throwaway line. When you look into the research, which they discussed at this national conference, basically you're at increased risk of developing osteoarthritis, greater chance of having knee joint degeneration long-term because of having had the injury. But that's increased by about 50%. But what's interesting is only about 50% of those patients ever develop pain. So you can have, which is a kind of well-known concept within rehabilitation, physiotherapy, and some aspects of orthopedics, that basically what's shown on a scan almost always has a very poor correlation to patient signs and symptoms. So yeah, that's something that in the general population, they may be stressing out about having more arthritis, but there's also a positive flip and spin that we can put onto that to suggest that, well, you may never know, because after you've recovered from the initial parts of the injury, you in all likelihood, you're going to be symptom-free long term.
Yeah, I think there's an emerging conversation that's infiltrating the public around that. There's a long way to go, but the radiological findings of osteoarthritis, if we want to call it that, on imaging don't always overlay with symptoms for patients or athletes.
Yeah. And it's an easy path that patients and trap that patients can fall into. And it's been shown in multiple studies across the body that once you get a high-powered image like an MRI, you tend to focus on the results of that and the language that the conclusion comes from the report: degenerative change, superficial fractures within the knee, ACL rupture. Like how all these words are interpreted is normally catastrophically from a patient, whereas there are some international guidelines that suggest that this knee injury, an ACL injury, is a joint sprain. And so when it's presented like that to the patient, it's a lot different, and they don't really take it quite as serious. But obviously, it's an important injury. But there's this whole narrative that comes along with the injury, as you said, like talking more general population level and how patients interpret that. And I think clinicians can step in and actually oftentimes frame it in a more accurate way and positive way for the patient. Yeah.
I think culture plays a large part in that around, particularly here in Australia. ACL injuries are seen, in the sporting population, AFL player, to be, this almost like in many ways a life sentence for their playing future and a black stain on their resume.
Yep.
So much of that plays a part too, right?
Oh, for sure. Like there's absolutely no question that how the elite athlete is managed trickles down to the general population, and the kind of language that you'll hear in the media, devastated, the athlete or club is devastated, the worst possible news, scans confirm they need surgery. This kind of language will often then drive an early surgery for the athlete. And then sometimes, and more often times than not, the patients can then follow that same pathway. So,
yeah, language matters, context matters, and being informed around science-derived options matters. And let's go there now. So what options, Kieran, does someone have if they've ruptured their ACL? We're speaking mid-2024.
Yeah. Well, there's heaps of options. And so I think that's probably the most important point. Surgery is one option. And there'd be a very, very strong research argument that it's the last option. It's never off the table. But all too often, I think the patients assume it's their only option. And if you look at statistics and if you look at the healthcare systems and if you look at what's happening in reality, as you said, I guess, in the court of public opinion, the patients believe that. And so that's not true. And that's the first key thing, is they've got options. So patients can have early surgery. So they could, after the injury, essentially get it done within a matter of hours if they wanted to. But, it's typically if they're wanting that pathway and they're committed to that, they could get it within a number of weeks or days or weeks. You can do a period of prehabilitation where you're allowing the joint to settle down, getting the knee range of motion full, getting your walking pattern more normalized, helping to trust your knee a bit more, getting it stronger. You can do a strengthening and conditioning program overseen by an experienced and trained physiotherapist with the option of surgery if your knee is unstable. You can do a bracing protocol, there's a few out there. In fact, we've known since the mid-1990s that you can brace the knee and increase the likelihood of healing. And you can also choose to adapt, which is this concept of deciding within yourself that, look, it's probably too risky given my goals and stage of life or where I see myself in the context of this injury. You can choose to not go back to high-level pivoting, which is one of the ones I think is often missed and not discussed with patients, because most of the patients I see, Brad, are general population, and a lot of them aren't so fussed whether they go back to a change of direction level one sport like soccer, rugby, AFL, netball. They just want to be able to play with their kids, keep active, run, trail run, ski maybe, play some tennis, which is a bit different. It's a different level and lower risk. And I think that's part of the conversation which should emerge more.
So there's, like you say, there's lots of options that exist. And just to loop back to your comment there, that surgery is not the only option and it shouldn't be assumed. We understand how that can be assumed, that's, in your words, the court of public opinions, many people's only thought. How did that get to be the case? how did we get to have this immediate thought, I need surgery, and then we'll work through some of these treatment options? And I know this is something you're very passionate about.
That's a tough one because there's always been this option to not have surgery. It's not like the surgery itself is elective. And I was a part of a scientific debate with a professor of orthopedic surgery, and he says he tells every single patient, you can elect to have this. It's not a life-threatening surgery. You can elect to have it or you can elect not to have it. And so we've known really since the 1980s that there's groups. There's a surgeon Noyes, is Noyes, and he would say, look, the rule of thirds was what he used to say, that a third of people need surgery, a third of people do well without surgery, and a third of people ultimately adapt, which is what I was alluding to before. But yeah, there's been propagation of surgical techniques, and a large part of that is industry driven and healthcare pathway driven. So particularly in countries like Australia, where you've got healthcare models that are really pretty skewed towards surgery. There's certainly no Medicare item number for early non-surgical opinion, bracing protocol opinion. It's a pretty seamless setup for surgery in Australian context, in the US context, in other westernized countries. And reading some recent websites on the industry itself, there is a lot of commitment to increase production around that. So that we're foolish to think that the business of surgery is not a factor. That is a factor. But in saying that, there's obviously patients who've gone down that pathway and been incredibly successful, being able to return to sport and function at a very high level. And so it doesn't mean that it's useless or we're sullying that. But it's just that when you start looking into the science of it, and the best quality science, and then the emergence of new protocols, it's a lot more nuanced than how we used to think. And human beings do have a tendency to be dichotomous. It's just the way we are. And especially when there's pain and injury involved, fear can be very high immediately after this injury. I've read some studies that would suggest it's equivocal to PTSD. And I've seen that play out in clinical reality, where the patient's incredibly, incredibly stressed. It's not uncommon for patients to be crying either in face-to-face sessions with me or in online consults. So yeah, there's been multiple factors that have led to it becoming this narrative that we've tied to surgery, but a lot of that is not necessarily scientific.
So there's a bit there, isn't there? There's as you reference it, the business of surgery, that's an industry. It certainly doesn't mean that every surgery that's been done hasn't been indicated. As you cited, there are great outcomes with surgery, but there's also got to be some level of balance around the discussion and heightened awareness around some of the options and also the outcomes, which we'll discuss.
Yep.
Kieran, let's just paint a picture. Someone has had an ACL reconstruction, missing roundabouts, timelines for recovery. What are the risks with that? Anything you'd share around that in general terms? So someone has elected for surgical reconstruction.
Yeah. Well, again, it depends on the type. So I had a semi-professional patient player come and speak to me wanting a non-surgical opinion on their knee, and they had the classic unhappy triad of a meniscus tear, MCL tear, and ACL tear. They were told they needed surgery on all three. And I said, well, how about we'll just wait and see what the scan looks like at 3 months. I didn't pick them up till about 4 or 5 weeks after, or they couldn't get in till then. And so the meniscus had healed, the MCL had healed, but the ACL hadn't healed. And so he opted for a LARS, which is kind of out of vogue at the moment. And he had that return to training 3 months post and has been playing all season, and he's going great. So that's rapid. But if you look at guideline based, that's an outlier. Typically, for pediatrics, the guidelines would suggest it's 12 months, and for general population, we would be looking minimum 9 months. And there's some studies that would suggest trying to return before 9 months puts you at significantly greater risk. And time's a factor. I don't think it's certainly not the only factor that we want to take into consideration, but it's not something that we should be rushing overall.
So it's a process. It's a large rehabilitation process to get someone back to, if they do want to take on their prior sporting endeavours. As we've both seen, being practitioners for many years, Kieran, there has been trends with surgical techniques come and go. You just mentioned Lars, which I recall, it seems like a decade plus ago was sort of proposed as this great way of seeing people return to sport much sooner with shorter timeframes. But then we also know from the science that the rate of return to sport is around 50%, whether someone has gone through a surgical process or has elected to not go down a surgical pathway, correct?
Yeah, well, the rates are the same, which is what a lot of people will find fascinating. So if you're wanting to go back to a high level sport, whether you choose no surgery or whether you choose surgery, the rate of likelihood of you returning successfully is the same. So that's from a scientific data point of view. Okay. But I guess the real world is you don't want to not have surgery, go back and your knee give way the first game. Likewise, you don't want to go through 9 months of rehabilitation after surgery and your knee buckle and rupture your graft. And I've seen both of those. So either way, there's still increased risk.
Yeah, I mean, the statistics do reference that about 1 in 5 people can have a second ACL injury in either knee after ACL surgery. And the risk increases to 1 in 4 for those that do go back to sport. As you'd kind of expect, the risk is higher. So I think we're not downplaying the role of surgery here. Of course not. There's a valid role for surgery, but at the right time for the right patient, of course. But it's not a magic panacea. And I think going through my physio studies before I started to look down the rabbit hole, I had a naive view that was the one best solution for everyone. And I even recall, and I reflected on this knowing we were speaking today, I was out running this morning, and I remember being at La Trobe University, a fairly progressive university internationally in the field of sports medicine, for a lower limb tendon symposium. And in one of the breakout sessions led by some well-reputed tendon researchers, the conservative management of ACL injuries emerged as a talking point. And I remember sitting there, this was about 7 years ago, thinking, if I'd ruptured my ACL, I'd be having surgery. But now fast forward to 2024, I think I've probably flipped the other way. I definitely wouldn't be jumping to surgery. I'd be taking a 3 to 6 month period to see what I could achieve rehabilitating it without surgery. So there's risks. That's all. I guess the point is there's surgery is not a guaranteed amazing outcome.
Yeah, and sometimes some of the rhetoric that I see bandied around from industry can make the consumer feel that they're like, when I hear the term gold standard, reconstruction is gold standard. That's not a scientific term. It's more of a industry term. So it downplays the idea that the patient could be at risk. So I guess what's key is the patients certainly need to spend a lot of time researching their options, as we're talking about. They need to weigh up the pros and cons of those options. And a lot of this really should be led by the first clinician they see. And I think this is a very, very key role of the physiotherapist, is to talk through those options in detail. So the patient should be able to espouse that back to them. And I've had some brilliant cases where, like, the patients, before meeting them, I had one guy write out a PowerPoint where he'd actually gone through and literally wrote a PowerPoint of all the different studies, and he wasn't even a healthcare professional. I had another guy have a complete mud map of different articles in red and green, for and against. So he'd come to his own conclusions just from he was an analyst by occupation, but he wasn't healthcare. So I think patients want, if they look into it, they can start to see that it's not something you need to rush. And I think that's a key message and a phrase that I'll use with patients. Look, I've had very, very few patients regret waiting. None I can think of off the top of my head, but I've had quite a lot of patients regret rushing early intervention. And so that's what I think is super important. Yeah.
Something that a colleague in the industry, Stephanie Philbay, who's obviously doing a great body of work around non-surgical options for patients with ACL injuries. Something Stephanie said on a podcast that really made me think. I've had 2 patellofemoral joint surgeries and am now 43 and probably dealing with a fair degree of changes in my joint, Kieran, and associated symptoms. And Stephanie commented that on the surgical side, there's a naivety that people are getting a new ligament and that it's going to function like their organic ACL did. They're not really necessarily taking into account the fact that the tibial tunnel drilling disrupt the cartilage, either side of the thigh bone, the femur and the tibia, the shin bone. And I think it's something that there is a degree of naivety around what effects that can have in terms of manifesting changes in the knee, and anything you'd sort of share around that. I mean, I look back, I regret having 2 patellofemoral surgeries. I wish I had have waited, but I felt like it was my only choice.
Yeah, I guess that's really hard. And if only we had a time machine, Brad, where you could go back in time to 1969 and stop that. But yeah, we've got to move on. You know, it's tough for the patients because you want to counsel them if they've had that type of outcome, but you want to try and still look forward and see. You know, I had a second opinion I gave as a part of a trainee specialist physio who'd seen a patient who had 4 surgeries, and she rated herself as only 50% better overall 4 years later. And I said, well, look, do you think you can actually improve? And she's like, yeah, I do. I think I can get better. And so there's always scope to improve. And in terms of the actual function of a reconstructed graft, if you look at it on MRI, and if you look at the shape of it, it's obviously, because it's a tendon, it does have a thinner structure than a normal ACL. It's flatter than a normal ACL, and the properties of it, so the collagen fiber type is different to a normal ligament. And so what Steph, I haven't actually heard that particular podcast, but she's correct in the sense we can't really say it's a new ACL in air quotes. That's not accurate. And there's a commentary by Evangelos Papos and Josh Zadro where they said a lot of patients are told this. They sort of said you're getting a new ACL. And I think that's not fair and accurate, and shouldn't be used in those terms. But there are patients who will need it because their knee is too loose to be able to do the things they want to do in everyday life. So there is absolutely a role, will always be a role for patients to have reconstructive surgery. It's just they could equally have their ACL heal normally. It could partially heal. It could attach to the lateral femoral condyle, the side of the knee, could attach to the PCL, and the patients, which I've seen, high-level patients return to change of direction sport completely asymptomatic long-term. So everything has to be laid out, and then we watch the patient like we would any other injury. And so I think once you break it down and start taking our time with patients and waiting, watching, rehabbing, reassessing, which is why I think the follow-up MRI, which for a lot of patients in the Australian context, looking at, it was actually a local surgeon here in Perth that suggested I do that. He said, well, look, our training is that if we don't operate, the patients are going to get more meniscus tears. So how about if we do another MRI and we'll see? And so that's when I started to see a lot of this healing. And so I guess then going back to the start, we're thinking, okay, well, what are we doing in between the first MRI and the follow-up MRI to potentially stabilize the knee and improve the outcomes? And that's where I think hopefully future research will help us better predict what type of tears of a ruptured ACLs. They tear differently. What type of tears definitively need surgery? What type of tears definitively need a bracing protocol? What type absolutely are going to be fine with a rehabilitation strength and conditioning program? So we sort of need multiple studies to prove that. It will happen. It is happening. It's just, this is probably going to take 10, 15, 20 years to answer those questions better. Yeah.
So a definitive classification system around, you've got this type of ACL injury, we recommend this based on the clinical experience, the science, your goals, like a holistic view on it. We're not there yet, but we will be in time.
Absolutely. And so that's where it becomes, no one has a crystal ball. And so that's where if you have the patient who's been promised the world and then it comes crashing down, it's hard to reconcile, because the current science literally cannot predict. We cannot predict the outcome, even at the elite level. We can have some certainty, a degree of certainty, but not absolute. And I don't think it will ever be absolute, but hopefully it should become more obvious. Yeah.
So, Kieran, the option to rehabilitate without surgery, in your clinical experience, you mentioned you've never had a patient that's regretted waiting to not jump straight to early ACL reconstructive surgery. So what does this rehabilitation without surgery entail? There's a fair conversation point at the moment around different bracing protocols. The cross bracing protocol has certainly got some attention within our industry, probably slightly out in the community. Can you just quickly speak to what the cross bracing protocol is, and then some of the other options people have for if they're not going down an immediate surgical pathway?
Yeah. So the cross bracing protocol is a method by which you can brace the knee up at a 90-degree angle, like the edge of a square type angle, for an extended period of time. It's about 4 weeks. The patients from there can then slowly straighten their knee out. That is a protocol that does need to involve a medical doctor, because there is a significant risk of getting a blood clot. And so you need to be on blood thinners, and you need to fit the inclusion criteria to be a part of that. So that's a specific protocol. My personal protocol is one that involves weight bearing and an extension block, so it's less aggressive. The patients can have their knee bent to about negative 30 degrees, and they have that for around 6 weeks. There's no mandatory blood thinning required, and they're able to bend their knee as much as they feel comfortable, and they can kind of weight bear as tolerated, just avoiding twisting, changing direction. And once that 6 weeks is done, they can kind of move from, they can either wean off the brace completely, or they can keep the brace hinges on just at the sides, and then again do a follow-up MRI at 3 months. There's some patients who either can't get a brace or don't want to get a brace, or you might see them at 5 or 6 weeks post-injury and they've started rehabilitating. I've got one at the moment who's a semi-professional rugby player here in Perth, and he just couldn't get in to see me. And we were chatting, and he started his own gym and rehabilitation program anyway. And so we just made some modifications to that and then started supervising him. And so that's something you can also do. And then if the intention is to go back to sport and they're young, active, or pediatric, certainly I would recommend us rescanning them to see if there's been ligament reattachment, and then checking to see if that ligament is functioning, because obviously there's also, when it comes to the quality of the ligament, we want it to feel as if it's stabilized, but in non-weight bearing ideally, and certainly in weight bearing the patient should have a stable knee and have no sensations that it's going to give way. And so those are the general protocols if you're looking to not have surgery and do a scientific rehab program or bracing program. Those would be your key options. And so I've had pretty good success looking at those and using those when the patients have it presented to them.
And the principles of, like you say, Kieran, not going into a range of motion brace, limiting the ability to go into full leg straight in or extension, but still being able to bend their knee right through range up until that point, as opposed to something like the cross bracing protocol where people are fixed, can't move. Is the principle of that not having the last 30 degrees or thereabouts of extension, whatever the range is it just to try and help promote the ends of the ACL being more approximated, or what's the rationale there?
Yeah, well, there's a few papers. There's a French paper actually from 2012 that had that similar negative 30 degrees extension block, and they had around 80% of the ACLs heal. There's a paper from 2016, Jacobi. There was a Swiss study, and they had basically when you bend the knee to a degree, yes, it draws the ends of the ligament together, but it also pulls the shin back to an extent. So it's almost like doing the opposite of the Lockman's test, which is when they pull the shin forward to test the ACL. So you're kind of putting the ACL back into its normal anatomical position. And then you have the effect of putting weight on the leg has been shown in a number of studies to stimulate the ends of the ends of the ligament, which can build collagen cross bridges. So scientifically, they call that mechanotransduction. So you have those physiological reasons to brace the person, but there's also just the practical concept of having a brace on reminds the patient they have an injury. Because if you've done enough of these, and I've done thousands, without surgery, the patients recover faster, because they haven't had the second trauma to their knee. In research, it's called second hit phenomenon, where the patients have, because the injury is intracapsular. But if you have reconstruction, it becomes an extracapsular injury. And so there's more swelling, there's the pain associated with the surgery. So you'll see the patients, they're in less pain pretty quick. And so they can get a little bit cavalier. So I like having a brace on, if nothing else, as a reminder that they have to take the whole process seriously. And so really, like I alluded to earlier, what would be absolutely best is if we could have some of these non-weight bearing protocols compared to a modified, less aggressive, to just rehab. And then we look for various types of tears. Is there actually any difference? Now, what we've seen in the past when we tend to do studies like this is it all ends up the same. So it makes us realize, well, maybe the brace is doing nothing. Maybe it's just the type of tear that is first occurred. And maybe what we're doing is less important. It's more just the actual injury and how the body recovers from it, as opposed to what we're doing externally, if that makes sense.
So how long, Kieran, is it a 6 month, like you'd counsel your patients, let's give this 6 months of concerted rehabilitation without surgery to be led by the leading light, which is let's not lose sight of the fact that it's clinical signs and symptoms that we are interested in. Does the patient feel unstable? Are they at risk of a secondary knee injury? What's their confidence like in their knee? How's it affecting their activities of daily living? How's it affecting their sport and recreation? So they're the leading light guides, I guess, telltale signs. So we're keeping an eye on those. But how do you account for people needing longer, reduced timeframes? Is it just based on criteria-based progression with their rehab and these other measurable things such as their confidence?
Well, I mean, you've touched on it. It's multifactorial for sure. There's at least 300 variables if you look at research evidence. We probably can't list them all now, but the Swedish guidelines, which have never been translated to English, they suggested it's 3 to 6 months minimum. Okay. And that's with a rehabilitation no brace. My personal belief and what I communicate to patients is it would be minimum 6. If you look at all these healing studies that we've got now, which there is level 1 high quality evidence that ACL tears can heal, when they heal, it's not done at 6 months. There's additional healing that takes place from 6 to 12. So the ligament looks darker, looks more condensed, can thicken and become more erect and upright. And so I guess we don't want to be rushing these patients at 6 months. So generally, I'm saying minimum 6, but probably 9 for the patients that are wanting to go back to higher level change of direction sport and activity. And so that's one factor. But then you also have additional factors, prognostically. So you have if someone's got a bone bruise, that's going to make sure it's a little bit longer, like a significant bone bruise, which is very common, over 50%. If they've got an associated meniscus tear, that's going to add more time onto the whole prognosis. If they've got an associated MCL, that's also going to clinically be more painful, going to be slower to rehab. Range of motion will take a bit longer. So, and if their patient's incredibly scared, that's obviously associated with a slower outcome as well, because they move slower. They don't want to progress through rehab. They may be fear avoidant. So yeah, there's all sorts of factors.
What are some of it's a big question, I know, Kieran, because there's so much nuance to each case in terms of each person recovering from this injury. But what are some of the clinical criteria you like to see as maybe non-negotiables for patients progressing, doing well with their rehabilitation without surgery approach?
Yeah. As you said, there's all sorts, but I probably put it practically into 3 phases. So the patients have phase 1, try to heal the ACL, recover from the injury, get the pain down, get your range of motion as good as possible within 12 weeks. So I have each phase as probably 12 weeks, 3 months. Symptom relief, healing the ACL, I'd call that. Then you kind of move into strength and conditioning, which often can start to take place, but is less important in the first 3 months because it's more therapeutic exercise, adherence to the bracing. Then you move into strength and conditioning, which is more gym-based. Obviously, they probably don't have to do as much rehab per se, but they still want to start to do strength and conditioning principles, still doing exercise 3 or 4 times a week. Depending on the case, that on average would take 3 months. And then you've got return to play and plyometrics, building up their running volume, this kind of thing, and return to sport drills. So those are my 3 general ideas that I would discuss with patients, and I think that works pretty well. It's pretty straightforward.
It's a nice simplistic model, isn't it? Heal the ACL phase 1 up to say 12 weeks. You cited that they may be using a brace in that period of time in your protocol, if you like. We'd call it Kieran's protocol. It could be, say, 6 weeks of not getting full extension for the variety of reasons you've espoused. Phase 2, strength and conditioning, gym-based work, allow another 12 weeks, up to 12 weeks. Obviously, this will be individualized. Phase 3, return to play, running workload, plyometric activities, drills, return to sport tasks, etc. So you're looking at, there's your 9 months there. And
pretty much,
I guess something that really jumps out to me is people are going to need to put the rehabilitation efforts in with or without surgery. So,
yeah.
So I think that's something people can't dodge. It's just the timing, whether they are open-minded to do the research and hopefully work with a practitioner that can give them a balanced view of their options.
Well, we, as healthcare professionals who are very passionate, and physiotherapists are very passionate about research, a lot of the patients, that's just well beyond where they're at. Like, the kind of questions patients ask me is like, can I kneel down on the ground? If in 30 years' time, will I still have to do exercises? Can I go for walks in the woods? Like, these are the kind of questions that patients ask. So physiotherapy in particular, I think, can sometimes run astray with the very empirical research, whereas at a patient level, they're wanting more basic questions answered. Have you seen this work? Like, that's the kind of questions patients are asking me. Super simple stuff. Mm. And the thing that I find frustrating is oftentimes in the traditional medical pathway, they feel rushed. They feel pressured. They feel hemmed in. And so, I really want to emphasize that the patients, if you're a clinician offering non-surgical, that you allow the patient a lot of time, because it's not something that you can breeze over in 5-10 minutes. It takes a lot of time to dig into. And yeah, I think that way you also avoid risks, medico-legal risks, but also just the patients. That's why the patients are so satisfied that I see. Overall, obviously we can't appease everybody, but I think you're going to help your clients be more happy by taking this kind of approach.
Spending time. This is an hour-long conversation we've had, and in many ways we've just touched the surface of these talking points. But that was the aim of getting you on, Kieran, is just to bring a balanced conversation around people's options if they do happen to have incur an ACL injury. Kieran, you're active in the space for both practitioners, for patients. Globalspecialistphysio.com is a fantastic repository of resources for those two groups, practitioners and patients alike. Anything coming up for you that we should keep our eyes or ears out for?
Yeah, well, we've got, in terms of, this is a great podcast, Brad, but there's more podcasts coming up. So we've got Dr. Stephanie Filbay and I are going to be on a Physio Network podcast where we discuss a lot of these things, even in further detail. And I think that's going to be really good because you've got a passionate expert clinician and then you've got a passionate researcher talking about more nuance. I think that'll be great. I've got a case example that I'm going to be presenting on a podcast for Physio Network of someone who was told they didn't fit the cross protocol. They didn't fit, they didn't fit, the ACL was not going to heal and that they needed surgery. They were told by 6 clinicians. We then took her through a rehab program, no brace, her ACL healed. So we've got cases like that, which I think, yes, it's a single case, but it just shows that there's so much more that we need to explore and discover and discuss. And then I run workshops for healthcare professionals where we discuss this in detail. I've got one coming up in Brisbane in next month, and that I think is going to be cool. And I like doing that either face to face or online. But my real passion, I see patients still a day a week, but my passion is to empower the clinician leaders with research to help them help patients. Kind of that model where leading leaders is something that I'm passionate about. So I think we need physiotherapy in Australia. We've got some of the best physios in the world and some of the real leaders on a global stage. And so that's something that I want to see develop and grow and build. And so, and also second opinions for patients. I think that that's something that, as you know, if you're going through the specialist training, that's something that we are specialists within our own right. So getting physiotherapists to see themselves like that is something I'm also passionate about. Yeah.
Yeah. You bring so much to the Australian physiotherapy landscape, Kieran. I'm certainly a beneficiary of that. So thank you. Every guest of the show, Kieran, gets asked 2 set questions. The first is, and we're going to make this topic dependent, but if Kieran Richardson could boil everything he's learned about ACL management down into one single piece of advice for the listener of this show, and we can assume that maybe there's 2 categories of people listening in: the practitioners and the athlete who has an interest in ACL recovery, so perhaps they've been injured. So maybe by definition, it's 2 pieces of advice, one to each camp. What would that be?
It would probably be the same question, and it's a bit of a Socratic one. It would be, you can't ask too many questions. So if you're a clinician investigating this topic, you have to be committed to continually questioning. If you're a patient and you've just had the injury, I've had a patient write out 3 pages of questions, and I love that. I actually thought it was awesome because you could see the mental gymnastics going on. So not in a skeptical way, but they genuinely wanted to know. And so I think that's the part of science that I love, is just not being too fixed on one view and just respectfully questioning. So that's probably what I would leave. Yeah.
And that applies, I guess, to the practitioners and the athletes out there. And Kieran, everyone issues a physical challenge for the week. What's Kieran Richardson's physical challenge to listeners going to be? don't rupture your ACL.
Well, the old joke that we used to say, I don't even know if this is politically correct now, but we used to say exercise is good for you, sport's bad for you. So, like, I think if you, so, and I love my sports, don't get me wrong, but I'm past my prime now. But I still love going and shooting some hoops. So, what's it? Find something, find 30. I think that's, find 30 minutes of something is always good. But yeah, don't feel like it has to be sports.
Exercise is good for you. Sport can be bad for you. That's rich.
Don't
Kieran.
quote me on that. Don't quote me on that.
That's thought provoking, and I think everyone that's laughing along can reflect on that and probably see the kernel of truth in that. Kieran, thank you for your time. It's been a great contribution to this show. As I mentioned at the top of the show, there's plenty of places for people to find you. I'd encourage people to reach out, connect, engage with the resources, and thanks for stopping by.
Thanks for having me, Brad.